Good afternoon, everyone, and first of all, thank you for inviting me here, and thank you for the kind introduction. The last time I came to Nashik was to collect my MBBS degree certificate from MUHS, so that was a fairly long time ago, so it feels great to be back here. So in the next 30 minutes or so, we are going to be talking about febrile neutropenia. Now, it's a vast topic to cover. So what I thought was that instead of, going through some of the theory aspects of it, what we'll try and do is how to build an approach towards a patient who has febrile neutropenia. So just for the introduction's sake, we all know what febrile neutropenia is. Many of us are hematologists here. So what neutropenia means is that ANC below 1500, so that is mild neutropenia. But what we are really worried about is the severe neutropenia, which is less than 500, and the profound neutropenia, which is less than 100. Now, when I talk about febrile neutropenia, the most important question is that, why is this patient neutropenic? So, patient who is neutropenic from therapy is very different from a patient who is neutropenic from the disease itself. And that's why an approach to febrile neutropenia has to factor in the reason why this patient is neutropenic. So, for example, if my patient is an AML patient who has undergone a haploidentical stem cell transplant, now is day 15 of transplant, his WBC count is still 10. We are a little worried about primary graft failure. By this time we would expect some sort of movement in the WBC count. This patient now spikes a fever. The approach to this patient would be very, very different from someone, let's say, who is on a biologic for rheumatoid arthritis and now has developed neutropenia. So, for example, if someone is on Azoran and has developed neutropenia, these two would be completely different patients. So first and foremost, the approach to febrile neutropenia depends on what is the underlying disease. Now, if you look at an immunocompromised patient, we often use the word immunocompromised for a very wide spectrum of diseases. So right from the mild immunodeficiency of pregnancy or from the mild immunocompromised state that pregnancy is to the very profound immunosuppressed patients. So for example, the patient that I described, a patient who has a relapsed AML, now has undergone a haploidentical stem cell transplant. This is a very broad spectrum of immunodeficiency. So whenever I am dealing with a neutropenic patient or for that matter an immunocompromised patient, from an infectious diseases point of view, the first question is what arm of the immunity is suppressed. So for example, if you have someone who is neutropenic, then you have to look at the qualitative as well as the quantitative neutropenia. Then you could have someone whose humoral immunity has been compromised. So the B cell immunity has been compromised. Then you could have someone whose T cell immunity is compromised, and then they could have mixed defects. So let us look at the approaches towards these patients quickly in a couple of minutes before we actually go over to the management of febrile neutropenia. Now, I have a patient who has neutrophil dysfunction, including both quantitative and qualitative. So, an AML patient presenting with neutropenia. This is the classic example of a patient who has both qualitative as well as quantitative neutropenias. So, what am I worried about here? So, obviously, I am worried about infections in whom normally the neutrophils play an important role. So, the body's response to different pathogens is via different pathways. So, for example, if you look at your usual bacteria or your typical bacteria, staph, strep, pseudomonas, E. coli, Klebsiella, Acinetobacter. If you look at your typical gram positives and gram negatives, the neutrophils are a very, very important barrier of defense against them. This is for two reasons. One is the phagocytosis in which they are involved, and more importantly, they are also important protectors of the mucosal linings. So when someone is neutropenic, there could be easy translocation of these organisms into the bloodstream. So when I am looking at a patient who is neutropenic, I am worried about typical bacteria. So again, staph, strep, your typical gram negatives, and I am worried about molds as well as yeast. So I am worried about candida, I am worried about aspergillus, I am worried about mucor, I am worried about other molds as well. Things like fusarium, pigmented molds or demataceous molds, pseudosporium and so on. So these are really my main enemies when I am looking at a patient who has quantitative or qualitative neutropenia. Whereas if I have a patient who has a humoral dysfunction, so he has a B cell mediated defect, so someone who has undergone a splenectomy or who has a B cell mediated defect, I am worried about encapsulated organisms. So I'm mainly worried about encapsulated organisms and PCP. So again, the underlying disease or why this patient has become neutropenic is very, very important. So let's say I have someone who has a hereditary abnormality and now has undergone a splenectomy. Now comes to me with fever. This approach is going to be very different from an AML patient. Now, what am I worried about in patients who have T-cell dysfunction? So who has T-cell dysfunction? Either because of the disease itself, patients who have T-cell leukemias or lymphomas, or because of therapy. So for example, biologics or TNF-alpha inhibitors, interleukin inhibitors. What am I worried about? Normally, T cells are very, very important host defenses against intracellular pathogens. So TB, mycobacterial pathogens, brucella, listeria, salmonella, and the endemic fungi. So histoplasma, cryptococcus, and so on. So really, when I look at patients in the hematology setup, a lot of different factors need to be considered, as I mentioned, and there could be mixed defects. So not everyone, will have a particular defect. So for example, if my AML patient has had a relapse, he has received the flag regimen, or maybe he has received steroids for some other reason, now has gone into a haploidentical stem cell transplant, he no longer remains just a neutropenic patient. A lot of times these patients can have mixed immunological defects. So little basic understanding of immunology is very important when we are dealing with patients who have infections in the immunocompromised setting. So again, the underlying disease, the therapy for the disease that he has received, and the duration of neutropenia, very important. Whenever I get a reference for neutropenia in the solid cancer setting, the first question to the oncologist is, how long is the neutropenia going to last? Because that tells me a lot of things, about escalating therapies, about what workup to send, about what organisms to suspect, and so on. So with this brief introduction, let us go over to the first case. This is a patient with acute myeloid leukemia. He undergoes his 7+3 induction chemo regimen. Day +4, so on the 4th day after his chemotherapy, he develops fever. As is the practice in most centers, most centers give prophylaxis or antifungal prophylaxis to AML patients who are on induction chemotherapy. Now, when you talk about antifungal prophylaxis, you have to really ask yourself, what kind of antifungal prophylaxis am I giving this patient? Am I prophylaxing him for yeasts, which means am I prophylaxing him mainly for candida, or am I also giving him prophylaxis against molds? So by molds, I mean fungi like Aspergillus, Mucor, and so on. So usually for AML induction therapies, we give mold-active prophylaxis. So this patient has been on posaconazole, which is a broad-spectrum antifungal, has activity against most of the molds. His WBC count at this point of time is 340. There are no other localizing symptoms. So what localizing symptoms are you looking for? Whenever my ID fellows see a patient who has febrile neutropenia, especially in the setting of an AML, what are they supposed to look at? So most important things that you need to look at, lung exam is of course one part of it. The normal exam which you do for any patient with fever has to be there. Because remember, these patients are not going to exclusively have fungal or immunocompromised infections. They can very well have community-acquired infections as well. So there is no rule that an AML patient who has febrile neutropenia has to have Mucor or Aspergillus or Candida. He can very well have dengue or chikungunya or community-acquired infections. So you have to consider some other differentials in addition to an immunocompetent patient. Now, so important things which should not be missed here are, one is looking for oral thrush. Pretty common in our settings, especially with AML, with prolonged neutropenias. Looking at signs of mucositis. So what kind of diarrhea does this patient have? Does he have dysphagia? Looking at skin exam findings, and later on I'll show you some cases wherein skin exam findings have helped in picking up the cause of febrile neutropenia. And rectal exam, again not a digital rectal exam, but at least a local inspection. Looking for abdominal signs like neutropenic enterocolitis or typhlitis and so on. So these are some different things that you look for in these patients apart from your immunocompetent patients. So there were no localizing signs or symptoms. What would you start at this point of time? Now we all agree that a neutropenic febrile patient merits antimicrobial therapy. This is not a patient in whom you would wait and watch and look at blood cultures and then start antibiotics. So febrile neutropenia is an absolute indication to start antibiotics. The important question is, what would you start? If you look at different guidelines across the world, they would factor in local patterns in these patients. So the general principle here is that you would give an agent which has activity against gram negatives, including Pseudomonas, and which is likely to cover at least 70 to 80% of the resistance patterns in your setting. Now, if we look at our own data, then we have about a 40 to 50% prevalence of ESBL organisms. So what are ESBLs? Extended spectrum beta-lactamases. These are typically resistant to all cephalosporins and for which carbapenems are the drugs of choice. If we combine piperacillin, tazobactam and aminoglycosides in our setup, the sensitivity is almost 80%. So this is something that you have to talk with your microbiologist, that what is our sensitivity or what is our antibiogram for the hospital for important pathogens that you would see in this setting. And as I mentioned, important pathogens in this setting would be Klebsiella, Pseudomonas, E. coli and Acinetobacter. So as long as you are giving a gram-negative agent which is going to cover 70 to 80% of the bugs in this sort of a setting, you have the right kind of therapy for febrile neutropenia. So usually we start off with piperacillin, tazobactam, maybe cefepime, sometimes with an additional aminoglycoside. More importantly, what workup would you send at this point of time? Now, we all agree that we would send blood cultures. Now, what markers help us? There are a lot of options which are available to us in a febrile neutropenic patient. You have fungal markers like beta-D-glucan, galactomannan, you have procalcitonin, you have interleukins, you have blood cultures, CT scans. Now, many labs are advocating direct from blood panels. So, they advocate that, we have a neutropenic fever panel or a transplant ID panel. So the choices are tempting, but we need to pick and choose, based on evidence, what are we going to order in terms of diagnostics? Because diagnostic stewardship is also important in these patients. It's a long battle. You can't blindly, send everything on day one. Usually, a good starting test would be your markers. So either a CRP or a procalcitonin or ideally both. If you have access to interleukins, also combining interleukins with that. What is the importance here? So let us talk about procalcitonin in neutropenic fever. Day one of febrile neutropenia, if I send procalcitonin in someone, what is the sensitivity? The sensitivity at best is going to be 60 to 70%. So it's not the initial procalcitonin that I'm looking at. I'm looking to trend the procalcitonin in many of these patients. Now, procalcitonin in combination with interleukins actually can be useful. So, for example, in our transplant setting for our BMT patients, especially who undergo a haploidentical transplant, we usually order an interleukin 6 and 8 along with procalcitonin. But the take-home message here is that at least trend the bacterial markers for the first couple of days, because we want to see in which direction this patient is heading. Is this patient heading in the direction of a bacterial infection, bacteremia, or is this patient heading in the direction of a fungal infection? These are two really important differentials that you start out with. Now, there are many other differentials in febrile neutropenic patients which I'll come down to. 20 to 30% of the times, even as quoted in Western literature, you may not find the cause for febrile neutropenia till the end. Resolution of neutropenia will be equal to resolution of fever. But till then, every attempt has to be made to establish an etiological diagnosis. Now, we have to remember that fungal organisms can also elevate the procalcitonins, but median fungal procalcitonins are not very high. So, if you look at literature, median fungal procalcitonins are usually around 1.5, 1.8, 2.2 in most studies. So, if I have an exaggerated procalcitonin on day one, procalcitonin of 25 or 30, I know that this patient is very likely to be bacteremic. In fact, as the procalcitonin value starts going over 50, especially 75, more towards 100, this is even more specific for gram-negative bacteremia. So, an initial procal has to be taken into the picture, in the overall picture, and you have to trend the procalcitonin rather than sending a single value. So usually what we start off with is procalcitonin and interleukins in our setup. On the first day, both were negative. On the second day, now the procalcitonin jumps to 24. So now I am very suspicious of a bacteremic process in this patient. So this is not the time wherein I am going to be looking to send a beta-D-glucan or a galactomannan or get a CT scan or order a CMV PCR or see if this patient has a TB. Focus on your standard gram-negative pathogens in this patient. Now, the important question is, how do we optimize the microbiological aspects of this? So try and send more sets of blood cultures. Although if you look at studies, more than 2 sets of blood cultures really don't add much to your neutropenic patient. But try make sure that these cultures have been sent in the right manner. As I mentioned, procalcitonin can take about 12 to 24 hours to elevate. So don't go by the first procal. A lot of times by day 2 or day 3 of febrile neutropenia, if you have sent 2 or 3 sets of blood cultures and have had 2 or 3 values of procalcitonin negative, you are heading with fair certainty towards a non-bacteremic process. So then the lab calls you saying that, this patient is growing gram-negative bacteria in blood cultures. This is the time to, get all your microbiological workup in place. As I mentioned, there are labs which are advertising direct from blood panels in febrile neutropenic patients. At this point of time, globally, these panels are not approved. So it is tempting because, we are looking at quick diagnosis. So day 1 of febrile neutropenia, quick bedside panel, it shows you E. coli with NDM. At this point of time, there are not enough studies to validate this kind of an approach. So where these panels really should be sent is that the moment we have growth detected. So if the lab tells you that there is a gram-negative bacteria growing in blood cultures, that is the point of time, I would like to know what the enzymes are. So then we send all these enzyme panels. So this patient now is showing Klebsiella, but more importantly, he is showing SHV, CTXM, NDM, and OXA48. So there you have all these enzymes. This is the time, to refer to your microbiology department or to an infectious disease colleague if you have access to one about how to interpret these panels. So now just looking at this, I know that, SHV and CTXM are likely to be ESBLs, and NDM and OXA48 are likely to be carbapenemases. So now looking at this panel about 48 hours before we have the actual susceptibility results, I know that this is a carbapenem resistant Klebsiella. So this is the real utility of these panels in this setting. You could also do a biofire panel. Again, it's good because it's going to give you access to some of these enzymes again. So talk to your microbiology lab about how we can optimize diagnostics of gram-negative bacteremia before we get the actual susceptibility results. See, once you get the actual susceptibility results, the practical implications of trying to find out what enzyme there is are limited. But before you, what I really want is, I want access to these enzymes about 24 to 48 hours before I have access to the actual susceptibility patterns. Then a couple of important things, again, gram-negatives is too large a topic. In fact, we do conduct a 5 to 6 day course on gram-negatives if anyone is interested in coming down to Pune. But as far as gram-negatives are concerned, two important aspects, because these are important in the hematology setting. Always talk to your microbiology lab about how are we testing for colistin. The automated systems that are used in majority of the hospitals across the country actually can underestimate colistin resistance, which means that they can falsely tell you that colistin is sensitive. Whereas if you do the proper broth microdilution testing, the actual colistin resistance is far more than what these panels give. Now we have a number of publications from that, which I can share, in the question and answer session. The other thing is, synergy testing. So as we move towards BL-BLI based regimens, so for example, Zavicefta has become increasingly popular, ceftazidime avibactam, plus or minus aztreonam, so always test for the susceptibility testing. So if you do have access to enzymes, your gram-negative management does become a little bit easier. I wouldn't say easy, but a little bit easier. So for example, this patient now is also producing an NDM. What do we know? That NDM cannot be destroyed by any of the beta-lactamase inhibitors. So once I have NDM, that is the time to also include aztreonam as a part of the regimen. Or if I have a pure KPC or OXA48, my approach is different. Again, the point here is not to go through the gram-negative algorithm, but the point here is that we have to optimize microbiological diagnostics. So you will see many of the cases which fit into the first case, that if you continue to trend procalcitonins, continue to trend blood cultures or send blood cultures, by day 2 or 3, patients who are bacteremic will declare themselves. Coming to the next patient, this is not a patient who declared himself to be bacteremic. So 60-year-old elderly male, so who started on azacitidine and venetoclax for his AML. WBC again is in the 300s, develops a fever. So again, similar to the first patient, but what is different now? 3 successive days, your procalcitonin is negative, your CRP is not that high. If you have access to interleukins, they are not that high. You have sent 2 or 3 sets of blood cultures by now, but he continues to have fevers without localizing signs or symptoms. Now, I have excluded patients who have obvious localizing signs or symptoms because that management is fairly straightforward. But this is a patient now who continues to have febrile neutropenia without any localizing signs or symptoms. You have done a fair amount of work to prove that this patient may not be bacteremic. He is on posaconazole prophylaxis. Again, AML on induction therapy, he is on posaconazole prophylaxis. But he continues to have fever. Again, there are no localizing signs. So you have made sure that there is no oral thrush, there is no cellulitis, there are no signs of typhlitis, there are no skin lesions in this patient. So what would you do? This is a good time to get a CT chest. Again, getting a CT chest before sending a galactomannan is a good way to go about it. Because remember, galactomannan is a marker of invasive pulmonary aspergillosis. If there are no pulmonary lesions, your galactomannan is not likely to be very useful. Now, this is a very obvious fungal consolidation, the so-called halo sign, wherein you see a consolidative lesion centrally and then peripheral ground glassing. But more importantly, when you see such a CT scan, what is going to be your approach? So remember, this is a patient who is on posaconazole prophylaxis. So one thing I want to know is what are his posaconazole levels. Why? I really want to know, has he broken through on posaconazole? Because if he has developed this kind of a picture with good levels of posaconazole, then I am worried about posaconazole resistant molds in this setting. So the best way to approach this situation is actually getting tissue diagnostics. So if you really compare studies, or if you look at studies comparing a bronchoalveolar lavage to tissue diagnosis, then tissue diagnosis definitely adds more to fungal diagnostics compared to a BAL. So this is the time, I would advise or request my interventional radiologist to put his needle and get tissue. But this is easier said than done in patients who have febrile neutropenia. Because patients of AML at this time are very, very likely to be profoundly thrombocytopenic as well. And they are profoundly neutropenic anyways. So tissue diagnosis may not be easy. But again, this is a multidisciplinary decision that needs to be talked out with the hematologist and with the interventional radiologist. So if possible, get tissue. Otherwise, what we need is markers. So then coming to this question, how do markers add value to my diagnosis in fungal neutropenia? Now, most of us have access to galactomannan, some of us have access to beta-D-glucan, and very few of us have access to PCRs like the Aspergillus PCR. So let us talk about galactomannan first. I think now it is routinely available. If not, the turnaround times of send-out tests are also not that bad with the galactomannan. So what is galactomannan? It is the antigenic response to an invading Aspergillus fungus. So which means that it is going to be positive only in invasive pulmonary aspergillosis. So if I have a high galactomannan, I am not going to be thinking about colonization. This is invasive pulmonary aspergillosis. The problem is low positive galactomannans and negative galactomannans. If your galactomannan is above 1.5, then it has very good specificity. So again, if your serum galactomannan is more than 1.5, there is very little doubt that this patient has invasive pulmonary aspergillosis or invasive aspergillosis at some site. The problem is negative galactomannans and in-between galactomannans. So let's say, the cutoff is 0.5. So if I have a galactomannan of 0.7, what do I do with that? That could either be false positive or it could denote other fungal infections which the galactomannan cross-reacts with. So what is the utility? The utility is in a neutropenic setting, its sensitivity is fairly high. So what is important is that in a patient of febrile neutropenia, if I have a galactomannan plus an Aspergillus PCR, which is both negative, then I can fairly certainly say that this patient is unlikely to have aspergillosis. Now, what is the utility of beta-D-glucan? So, what is beta-D-glucan? Beta-D-glucan is the normal component of the cell wall of fungi. So, it is present in Candida, Aspergillus, and PCP. These are the three main fungal infections which carry or contain the beta-D-glucan in the cell wall. So, again, what is the utility? If I have a quick access to BDG, then a negative BDG rules out candidemia with a fair amount of certainty. So again, at this point of time in patients with febrile neutropenia, I am also looking at markers which have negative predictive value. So if I send a BDG and if it is negative, I am fairly certain that this patient does not have candidemia. If I send a galactomannan and an Aspergillus PCR in a neutropenic patient combined, then again I am fairly certain that this patient may not have aspergillosis. So again, interpreting these markers is important. So coming back to our patient, this patient had serum POSA levels which were 1.45 minutes. Serum POSA levels were 1.4. So this patient has broken through on posaconazole. The recommended prophylactic levels are 0.7. So he has broken through with good levels. So then I am worrying or beginning to suspect azole resistance aspergillosis. So again, aspergillus in neutropenic patients probably I'll skip for the lack of time. Also I'll skip POSA versus isavuconazole levels. I think this is something that we could take up during the question and answer session. So important, as I mentioned, is skin examination in patients with febrile neutropenia. Never miss the skin examination. At least, in a high volume center, you will at least have 5 cases in the month in which you can diagnose the cause of or at least suspect the cause of febrile neutropenia based on the skin exam alone. So febrile neutropenic patient who has tender lesions like this, what am I thinking of? I'm thinking of septic emboli. So either bacterial emboli or candidemia. These are the kind of things I'm thinking of. A febrile neutropenic patient who has nail lesions like these and then maybe has a mold-like picture in the lungs, what am I thinking of? Definitely I am thinking of fusarium. So fusarium is a mold that can enter through the nail beds in neutropenic patients. We have had 3 patients of febrile neutropenia in whom we have sent the nail bed scrapings for sequencing and diagnose fusariosis, because there is no great way to diagnose fusariosis. There are no markers for diagnosing that. What does this patient have? This patient has something known as ecthyma gangrenosum. So again, people who are dealing with febrile neutropenic patients, we have to be conversant with this term. You do see this quite a bit. So this is necrosis followed by erythema or surrounding erythema. And what is the significance? It is very concerning for either Pseudomonas or for mold infections. So when I see this kind of a picture, I am truly worried about disseminated molds. Or you could have raised lesions which can have a variety of differentials. So for example, leukemia cutis or other molds in this picture. In maybe 1 minute, I'll wrap up the third case. So again, this is a patient with AML. I have focused on febrile neutropenia in the hematology settings. So patient with AML who underwent a transplant, now was given, he had a relapse, so was given a flag regimen and now has febrile neutropenia on day 3. So this is a patient, you have sent procalcitonin, you have done a CT chest, nothing else is positive. So what next? What can we miss out on? So then your options at this point of time are thinking about MRSA coverage, looking for viral etiologies. So again, you don't look for them upfront, but this is the time, HSV, VZV, CMV, they can occur late in febrile neutropenia. Consider other causes like drug fever, macrophage activation, hyperimmune syndromes. If you are going to get a bone marrow for disease response, also think of TB or PET-CT. We have had at least 5 patients in the last year whom we have picked up on a bone marrow gene expert being positive in otherwise occult febrile neutropenia. This is a patient with typhlitis. So again, neutropenic enterocolitis or necrotizing colitis needs to be kept in mind. And second last slide, this is a 19-year-old patient who underwent 5 cycles of chemo for AML. And with improvement in neutropenia, he had lesions like this. So any guesses what this is? This is hepatosplenic candidiasis. So in a patient in whom neutropenia is improving, think of hepatosplenic candidiasis. So in summary, thorough workup is the key. So invest in diagnostics. A lot of times, we get this that this patient is not affording. But actually diagnostics contribute to reduction of healthcare costs. This should be a multidisciplinary approach. So you have to get your microbiology, ID, hematology, radiology team on board to make these diagnoses. Know the local patterns because that will tell you what to start with, what to suspect, when to give mold active coverage. Blind escalation should be avoided. A lot of times, day 2 or day 3 of febrile neutropenia, patient has already reached polymyxin, piptaz to meropenem to polymyxin in 48 hours, but we haven't really bothered to see whether this patient has a fungal lesion or anything like that. So blind escalation should be avoided. Always look at diagnostics. And toxicities, interactions of drugs have to be kept in mind. So again, thank you very much for having me. It was too short a time to discuss so many aspects, but I'll be happy to take up the questions. Thank you.